I'll pass the chair now to Paul Huras, who will lead the next session. Paul?
Thanks, Frank. Could I ask Tom and Andrew to come up? I don't want to be up here by myself. First of all, I should make sure that everybody recognizes that in your booklet, the description of my background, I should make it clear I am not the Vice President of Quality Improvement for Health Quality Ontario. And in case you didn't know, I'm not the woman who has a diverse background with experience, etc. There was a slight mix-up in the presentation of that. So just in case you didn't know, not that there's anything wrong with that, but I am the I am the CEO of the Southeast Local Health Integration Network, and I'm pleased to be here. Thanks very much. This session, I think, is extremely timely, certainly for Ontario, but hopefully everyone across the country feels that this is quite appropriate too. And I really appreciated the discussion from the panel this morning with Yves and Jean-Louis and Greg, and then just now with Joshua. And I do think quality is an important issue at the system level as well as at the frontline level. I should say I obviously have a bias, a very strong bias, being a LHIN CEO, but I thought Ontario stopped being the control group in 2005, and in fact, we may actually be the test group now. So, so there are other provinces. We're quite fortunate with the panel today, and I'll introduce them. We have Dr. Andrew Everett, who will speak first. Dr. Everett is a family physician in Brockville, Ontario, in the LHIN I look after, and he's the board chair of the Upper Canada Family Health Team. He's a primary care physician, and he's our primary care physician LHIN lead for that area, so he has a clinical leadership role. Andrew is from a small country called Lesotho that's engulfed by South Africa, a very small country there, and he's a graduate from the medical school at the University of Cape Town. And it's been my pleasure to work very directly with Andrew, and his advice has been extremely helpful to me, and I greatly appreciate it. We also have Dr. Tom Noseworthy, who many of you know. He's a professor. He's an associate chief medical officer of the Alberta Health System. I'll just give you some background. You can read the detailed background, but he's a professor of health policy and management at the Department of Community Health and Sciences and the O'Brien Institute of Public Health at the University of Calgary, and has been an academic all his life, and told me earlier that, you know, I've been in this role all my life, but really had this opportunity to work directly with policy development, et cetera, with the government, and took that opportunity. He was the Associate Chief Medical Officer of Health of Strategic and Clinical Networks. Tom's work has been recognized broadly by the Commonwealth, by his country, by the province, by the university, by his peers. So really an outstanding research and expert and well-respected. And he's also a member of the Order of Canada, which I think is always very impressive to any Canadian citizen. We also had Dr. Robin McLeod, but unfortunately she had to give a late regret and is unable to participate today. So that has freed up some additional time for Andrew and Tom, but more importantly has freed up time for you to ask more questions, etc. And perhaps not as fortunate has given me an opportunity to say a couple of words also. So I want to talk about the clinical leadership from an Ontario perspective and from a LHIN perspective. Clinical leadership is extremely important. I find it's very important for doctors to be talking to doctors, and that advice to come to us from doctors talking to doctors, and certainly talking to us too, The role of, in the LHIN, we started off with emergency department clinical leads, critical care clinical leads, then moved on to primary care critical leads. Many LHINs have multiple primary care clinical leads, and the role of those clinical leads to engage their physician peers and to get advice and get an understanding of what are the issues that are facing them and what the LHIN could be doing to help them with those issues. I found it extremely valuable for us, and my understanding from talking with physicians is that they have found this extremely valuable too. Andrew gives us much more time in his role than what he's paid for, but it's extremely valuable time. I should also take the opportunity to talk a little bit about the patients first, because there are some people in the audience and across the online who are not aware of patients first, and even people in Ontario may not have a full understanding, and I would not say that I have a full understanding either. I think I do, I hope I do, but it is evolving, I think, on a day-to-day basis. But the clinical first piece is probably one of the most major transformation pieces in Ontario since LHINs were put in place, and again, I'm speaking with tremendous bias here. But this is going to have an impact on the healthcare system in Ontario, but also an impact on LHINs themselves. So there's really four basic components. And the one that a lot of people have focused on is the CCAC becoming part of the LHIN, and actually the LHIN moving into operations, which it had never done before. That's pretty significant, but if you really look at it in the first instance, that being the first year, it's really more of an administrative move. It does need to lead to major changes and improvement in home and community care and helping that better link perhaps with the rest of the healthcare system. But in the first instance, it's really an administrative change. So I don't see that as the number one piece or the most important. I see it as extremely important. But there are other components of this change that's being proposed that I think will also have a big impact. Public health being better linked. Most regional health authorities have public health linked better to the regional health authority than in Ontario. This will happen now, and with that we will bring the expertise of the medical health unit to the discussions that take place at the LHINs, but we'll also have that value of population-based planning augmenting the health system planning that LHINs currently undertake, and should really allow us to better reflect the needs of our communities. The next piece is primary care, and there was a lot of discussion about primary care reform this morning. Primary care will be closer linked to LHINs than it ever has been before. And, you know, the minister has said to us from time to time, we've given you a very difficult job of integrating the healthcare system, but we haven't given you all the tools. We will give you all the tools. Meaning the big part of primary care, other than community health centers, are not connected that directly to LHINs. Now, some LHINs have informally created that relationship, but it's not formal in any way. So in the first instance, again, planning, including physician human resource planning and performance, will come under the responsibility of LHINs, and then that sets the stage for further evolving that relationship between LHINs and primary care. So that's another very, very important piece of the patient first change and proposal. The last piece are these sub-LHIN units, which I think is the big piece. It's the opportunity to look at vertical integration. Many LHINs are working on horizontal integration, how hospitals will work together across the system, how they will, addiction to mental health will work across the region, etc. But vertical integration will be identifying these natural sub-LHIN areas that can really focus on the vertical integration of how primary care works with hospitals, works with long-term care, works with addiction and mental health. And it is my hope that in the Southeast, a family doctor such as Andrew in Brockville will have the same access to addiction and mental health services, for example, as a doctor in Belleville. And so this is bringing vertical and horizontal integration together in a matrix relationship. So those are really the fundamental four components of this proposed reform. But the other piece that is lost and maybe not well respected is this issue of clinical leadership. And the deputy has been very strong with the LHINs in saying, I want to see stronger clinical leadership. This has to be a foundation of this, this change in this proposal. And so I see that expanding much beyond the primary care physician LHIN leads, the emergency department LHIN leads, and the critical care LHIN leads to clinical leads for the LHINs and more primary care physician LHIN leads throughout those sub-LHIN areas. So this is a timely conference, and I'm pleased that we have these two speakers this morning to talk about some building blocks in Ontario, different parts of Ontario and Canada, Alberta, that will really help us understand the opportunities to build on what the experience is today. So I'll start with Andrew, and welcome, Andrew.
So I feel like I'm here to further test Jean-Louis' hypothesis of intellect and optimism. What I'm prepared to say is I'm very optimistic. Really, I am mostly a primary care provider. I spend most of my time in the office and somewhat in the hospital, and I have a focus in palliative care. So what I can say is that it's been very interesting for us to be deeply involved in the test of change that really was HealthLinks, and I want to just go through the sort of nuts and bolts of what we did with that. I am, as you know, employed by Paul, and I have no commercial bias in this. I just thought I'd do a quick refresher on HealthLinks, specifically for the Southeast LHIN. I know that all of us are not necessarily Ontario-based. I know exactly what HealthLinks are, but it really has become a province-wide initiative focusing on patients with complex needs. And the current definition is people who have 4+ chronic conditions. They are definitely failed by our siloed system. There's no question about it. To date, approximately 2,000 patients have received coordinated care plans in our LHIN, with at this stage 3 unattached to a primary care provider, and I think we'll have a solution to that. I think the issue with this is it's one thing to identify these people with this disease burden. It's another thing to build a plan, but you need an anchor, and the anchor is primary care. And the 3 bullet points that I highlight there are really from the ministry website around HealthLinks. What we've done in the Southeast LHIN, and this has been an initiative that's gone on for a long time, initially the primary care lead for the LHIN was Jonathan Kerr, and Jonathan was meant to be here today, and I'm not quite sure what happened with that bit of scheduling. He was very optimistic and engaging, and certainly was a very powerful voice for primary care across the LHIN. And it tells you a lot that now 3 of us share his one job. And really what it comes down to is he was at the forefront of this, and basically I want to just illustrate this map to explain to you how we did this. These are the 7 HealthLinks in the Southeast LHIN. I am the lead for the 2 on the east, which is the ones to your right. And the interesting thing in the Southeast LHIN, the population is about 500,000, which kind of goes back to the optimum size for regional health authority. The 2 HealthLinks that I work in are 50,000 patients each. So when we talk about sub-LHIN regions, that's another matter for discussion, because we might be, in fact, too small. The way this started was basically the LHIN looked at the data by postal codes and where patients accessed their care. So that was the starting point for this. And the map was basically drawn up on the basis of what town or city did you drive to access your care. So the initial map did actually not look like this. And then what happened was Paul and Jonathan and other people from the LHIN took this out on a roadshow and spoke to boards, spoke to primary care providers, and we actually redistributed the lines. They were not substantial moves, but they were small moves to account for referral patterns or natural primary care provider aggregations. To do this, it has required us to be aligned clinically, and as lots of you know, there's no one like a physician to bear a grudge forever. Here are sort of the highlight points for me. I think the part in the primary care led piece I want you to understand is this is administrators, this is managers, this is frontline healthcare deliverers, this is nurse practitioners, this is RPNs, this is physicians. And the way we started in our little corridor, which is called, the one I'm in is called the Thousand Island Health Link, is we had a transformative meeting where basically it was an open door meeting, anyone could come, it was facilitated. Jonathan was one of the leaders of the group that facilitated, and we basically posed to the group, how do you see your group's ability to transform healthcare in your small region? And we set, at that point, this is pre-coordinated care planning, 5 goals. One was 0 unattached patients, which we've managed to do. The other was ER diversion, which we've not got forward on. There are some disincentives there. The other was setting up a congestive heart failure clinic as an outreach from Queens at Kingston. We've done that, but it's limping because we're unable to find resources to sustain it at this stage. The other was sort of better integration with mental health and addictions, and this has been a LIN-wide initiative, and we're starting to get there. And I forget what the 5th one was, I should remember. But the 5th one was actually integration, I don't know what the right to put it is, better referral pattern to specialists, better information delivery to specialists, and better flow of information back to us, keeping the patient at the center. I think patients spend a long time waiting to find out when they have an appointment, if they have an appointment. They have little choice in scheduling that appointment. You know, that appointment could be on, your 50th wedding anniversary, but if you waited 12 months to get that appointment, you go to the appointment. And I wonder about that a little bit. But really what we've been allowed to do by the LIN is we were pretty much given a blank canvas. There was clearly a frame around it, and it has morphed into what are 7 health links. And the interesting thing as we've gone along is the health links are culturally quite diverse. I sort of advocate / represent two health links, and they couldn't be more different. This could be, British Columbia and Quebec, and it's quite interesting because the boundary is about 15 kilometers from where I live. It's quite interesting. And so it goes to the part of fostering local innovation. And there are lessons to be learned by both approaches. And what the most interesting thing is, as we've collaborated and worked together, we've actually shared this information back within the 7 health links, and we've kind of morphed into one model. So though we were allowed to start very widely divergent, as we've gone along, now there have been some levers applied to us, we have slowly morphed together, and there still is a very strong sense of ownership. And so some health links have 100% primary care provider engagement, meaning that they have face-to-face worked with every primary care provider, and I think the lowest is 50%. The challenge is in areas where there are lots of solo providers. The health link I work in, there's one solo provider. Everyone else is in a group practice. Much easier to spread information within a group model. Much more difficult in a solo practice. The other interesting thing that we've done in terms of this is that the Southeast Learners deliver this, and I apologize for the font. I know with my glasses I can't read what's on that from here. So this is the dashboard of what is called the Southeast Health Information Integration Portal. The acronym is SHIP. This is a web-based platform that requires us to basically VPN into one of the hospital systems so it's a secure site. The reason I've put this up, I work in a site with 2 nurses, 1 nurse practitioner, and 2 family physicians, so that's our aggregate group. And this is our data for the last year. The data is not clean because there are lots of duplicates there, and we're still working at debugging that. This works on the databases that submit billing information from the hospital, and we use that information to translate it to encounters. The most interesting thing is that I know when someone checks into Emerge, I know why they've checked into Emerge, and I know their CTAS score. And Paul loves to hear me say this. I've called people in Emerge to say, come see me in the office, because what happens is the assumption of most people is that they can't get in to see you, and so they go to Emerge. They don't pick up the phone and call to see whether they can be seen. And to my line of thinking, waiting 3 hours to see your primary care provider or someone who's in the primary care provider group is much better than sitting 4 hours in Emerge. We've still yet to get people to see the value in that, and I think that's definitely an opportunity for improvement. The other interesting thing on this is that if we were to drill down on any one of these numbers, it would actually give me the patients. So I can't do that piece, but it's interesting. And this has been developed by the Southeast LIN with tremendous amount of input from providers, mostly from emergency departments who will see value in this, and from primary care providers. It also has a page for the coordinated care plan, which is quite a valuable piece, particularly if someone lands up in Emerge at 2 in the morning. What we've done is had a third-party evaluation done of HealthLinks to date, and really it shows quite strongly the following items, and I'll just show them to you. Across the board, improvement in patient-centered care. As you can see, the starting point was really not very good in the first place. The limitation of this study and all information is the N. The number is fairly small in all of these studies. Basically, across the board, and this actually goes for providers as well, the vast majority of providers, but not all, and the vast majority of patients and families certainly reports quite strongly an improved experience. And the improved experience goes with fewer touches to the healthcare system, fewer times that we drop the ball in transitions of care, and generally improved outcomes. This is the utilization piece. We always have to go back to this to show it. Small numbers, 4 HealthLinks. The trend is consistent across all, and whatever that number may be, I don't know what the significance would be in terms of the statistical thing. There's definitely a change. There's no question about it. And these are small tests of change, collaborative, multifaceted groups, different healthcare delivery models, everything, and with some groups, solo providers coming in as well. Obviously, it's not all roses, as you'd imagine. The test of change, probably for us, that has worked the least well is focusing on a single disease, which for us was congestive heart failure. We need to think more about system and not about silos. We need to think more about the whole, which makes complete sense to all of you here. There are lots of disincentives to sharing, well established by the ministry, and I mean that as no disrespect to them. I know when these things were set up, they were well intended. But if we perform better in primary care with access, we reduce the funding of our ER department, which reduces the staffing, not just at the physician, PA, and NP level, but at the RPN, RN, lab, DI, everything. So the issue is we need to get that piece figured out. And the next thing is, if we want to collaborate in our bigger HealthLink area, there are 4 family health teams, 1 standalone FO, which is an acronym just for a physician-only group, and 1 solo doc. At the moment, if we cross-cover each other to provide expanded access on a 24/7 basis, we disincentivize each other in terms of funding. And so we would like to see geographically that to go away. Not to increase our remuneration, but to maintain our remuneration and take away the disincentive. So at this stage, it's very hard for a group of 3 physicians to provide 24/7 care to their practice. It's an unrealistic expectation. And clearly, as Paul alluded to, it's exposed multiple opportunities for us to work on the integration piece. I have to say, though, my sense is after 3 years in this, we are starting to break down the silos. There's no question about it. It's not anywhere close to where it needs to be, but there's change. Clearly, for us, we still feel an opportunity of improvement in terms of engaging specialists. It is challenging because the hospital environment has more pressures, I think, than primary care at the moment, potentially. And so it's difficult. In most of our communities, most of the specialists are hospital-based because we're a small urban/rural. We don't have big standalone specialist practices down the main street. Sharing information, and that's been alluded to earlier by the speakers this morning, it makes the task very, very difficult. I was actually at something yesterday where I figured out how many platforms I might go across in a day. If I'm very, very jacked up on caffeine, it's 8. In reality, it's about 3 on a daily basis. And the reality is there's useful information at every one of those platforms. There's duplication of about 90% of the material, maybe 80%. But there is unique information there that I think we could share. It worries me, the duplication piece, because we waste people's time. So 8 different people have entered 80% of the same information, and you've all heard the story. If you go through pre-op for a day surgery in hospital, I think they ask you 8 times, do you smoke? I'd want to tattoo that on my forehead, basically. But we need to be able to get around that. We shouldn't be asking the patient, since they checked in at registration, to being in pre-op 30 minutes later, are they now a smoker? Because they haven't started in the last 30 minutes. And really, the other thing for me is, we all understand it's the equity piece. And the equity is more than healthcare. It's actually poverty. The thing that we never really get to in healthcare is we're trying to fix poverty. You know, I hate to say it. I mean, if you're affluent and educated, your healthcare outcomes are better. And there's reams and reams and reams of evidence to that. We're being asked in healthcare to fix poverty. And I think we should continue to remember to advocate for that piece, because until we fix that piece, we're not going to go anywhere. There's my piece. Thank you very much.
So, Tom?
Morning, ladies and gentlemen. Thank you for having me. I certainly appreciated the opening session. It was important, got our attention, and there was a huge volume of work underlying it, so thank you very much for doing it. I want to tell you a story in 10 minutes. I'm not going to use graphs or PowerPoints, so I hope it works. By way of background, I've been a family doctor in rural Newfoundland, a critical care specialist in Edmonton, a hospital administrator in Alberta, and a university academic in both universities, and a department head in both, and they're very different places. I currently work at University of Calgary, and to correct the program, I'm no longer with Alberta Health Services. The Associate Chief Medical Officer's position changed 1 year ago by plan, appropriately, and Dr. Blair O'Neill is now my successor as the Associate Chief Medical Officer. So for 44 months, I left the university and moved into the healthcare system. I might use the word embedded researcher. That's a loaded term. I'm not going to probably use it. Let's just say I went back to what I used to do before and kind of enjoyed it. It was an eye-opener. It was no question about the fact I was lured by the fact that there was a single delivery system in Alberta. Could we, quote-unquote, make that work? And what would we have to do it? And I know the jury is still out based on the views that you've expressed here a few times today. And I want to suggest to you that if we could be left alone politically, that we will become the highest performing health system in this country. And in certain respects, are already starting to show that. And in other respects, we're embarrassed by our results, because we are amongst the most expensive, often only second to Newfoundland in the last 10 years. When you have oil coming up out of the ground, you spend more money on your healthcare system. Then you pay the consequences when you don't have that money. Regionalization in Alberta started in 95. We went from 229 hospital boards to 17 regions. I lost my job as a hospital CEO and went into the university. I had my choice, the church or the university. The church wouldn't take me, so I went to the university. During my training, I did a course from Avidius Donabedian, well known for his theory on quality improvement, and like a delightful man, brilliant, and he drilled into us the notion of structure, process, outcome. That structure notion being the context in which we operate, the process is all those procedural things and the way we do things, and then the outcomes, what we get. I thought I might turn things upside down today and not talk about the structures and the processes initially, but talk about the early outcomes, because, show and tell is not too interesting. We now think that we're starting to see a connection of the dots between what we're doing and what we're getting in terms of what we would call the triple aim. Let me start with one example. Stroke equivalent care. We could do this in all of Canada starting now, and we should. What happened was we had actually it was a large number of people, but particularly two individuals, Andrew Demchuk and Michael Hill, that have led the way as stroke neurologists in Calgary. They fundamentally have not been satisfied with the way we've managed strokes. And I got to tell you, as a rotating intern in 1974, when a stroke patient came to emerge, if they were particularly bad off, we brought them into the back room and called a clergyman. And that's not that long ago. And now we have stroke units that get good results. And it turns out, when you look at CAHSPR data, that the best 30-day mortality following stroke was in Calgary. And I know why it's that way. Strong, concerted team did a number of different things to change a lot. So we said to ourselves, okay, well, what does it look like in the rest of the country? And we started asking these questions in 2012 based on evidence and measurement, because that's when the SCNs were started, the Strategic Clinical Networks, which I'll go back to later. But this is the results part. What we said was, what would we have to do to get stroke equivalent care throughout the whole province? So what we're doing is not regional. It takes the best ideas regionally, but figures out how to scale and spread them to a provincial level, and that's not always easy to do, particularly in our political environment. This was an attempt to get organized quality of stroke care and rehab, using scorecards, a local advocate, the collective calls every month, all the things that you would do if you were trying to lever up best practice. Not rocket science, common sense, but good evidence and measurement. So what kinds of things? Well, early recognition, early diagnosis, quick imaging, rapid door-to-needle time. You know, that 4 hours matters. Can you get it down to 2? When you do, you save the brains of Canadians. So that's been the moniker. Family physicians, the communities have rallied around these ideas. We now have 1,000 people that have gone through stroke equivalent care. Now, this is in places like northern Alberta. Remember, 50% of our land mass in Alberta has 3% of the population. And many of those people there have a lot of chronic diseases, high Aboriginal population, high hypertension, what have you. 1,000 people have been through stroke equivalent care now. Stroke equivalent care really counts on getting the rehab started early. So get the fibrolytics in early and then start the rehab as quickly as you possibly can. Intensive functional rehab. 88% of our patients now receive physio and a complete assessment in less than 48 hours. It used to be 74%, up to 88. We have a 20% reduction in length of stay because we get our people out earlier and we bring the physio into their homes. We save 3,377 bed days. Functional improvement measured by neurologists at 30-day point shows a 17% improvement in people that have gone through stroke action plan. Patient-provider satisfaction has gone from 73% to 97%. There's been 17 fewer admissions to long-term care as a consequence of strokes. Not many, but some. And as of this morning, we finally did the calculation. There's been a 9% reduction in our 30-day mortality. 9% is not statistically significant. I bet when we go up to from 1,000 patients to 2,000 patients, we'll start to see a significant difference. We're changing stroke outcomes because we're levering best practice in a spread and scale, evidence-based way. Another example. Antipsychotic use, inappropriate antipsychotic use in our facilities. I was shocked to find out when we looked in 2010, 2011 that we had a prevalence of use of 41% of the people in our long-term care facilities were receiving antipsychotics. 40%, wow. It really crystallized for me when my mother-in-law got a dose of an antipsychotic one night. She was 100 years old. For 4 days, she was unresponsive to deep nail bed pressure, incontinent and what have you, and finally reversed. So what was the problem we were trying to deal with? Too many seniors were on antipsychotics inappropriately. We picked 11 early adopter sites. We picked them because they had high use. So in terms of the prevalence of antipsychotic use in the absence of psychosis, we were seeing the first 5 centers, 34%, 27%, 33%, 26%, 35%. Inappropriate use of antipsychotics. At the same time, Alberta was 28%, Canada, 32%. We should be doing something about that. The approach was get the early adopters, introduce a program, bring in an antipsychotic a guideline reduction, a toolkit, some guidelines, and start an interprofessional medication review, because why do people get on these antipsychotics? They come in on them, they're not stopped. They have a bad night, they're started, they're not stopped. So medication reconciliation, scorecards, measurement, all important. The early adopters using the RAI quality indicator had a 39.9% inappropriate use in the first month, and in the 12-month period it went down to 23.4%. So we said, oh, this is working. So we decided to scale it up. If you're going to scale up innovations provincially, you've got to involve those people that you're eventually going to touch at the very beginning. We now have fewer residents in daily restraints. We have less delirium. We have found, to our surprise, that we're seeing more people showing signs of depression. I guess you wake up and more people are depressed, so we're going to have to deal with that. But the overall statistic I'd like you to take away, province-wide, 27% we started with of antipsychotic use that was inappropriate based on the RAI indicators, now down to 18, which is the lowest in the country. And we'll take it lower because this group has got wind in their sails, and they've decided now to take this whole program beyond long-term care and take it into supportive living and assisted living. where we got a lot of those kinds of drugs being used. Let me try to come to a completion then and say, well, how has all this actually come about? Because we have some structures that undertook some processes to achieve those outcomes. And what it's all about is you will not ever achieve high performance if the top-down does not meet the bottom-up. I can't change stroke care from the administrative suite of Alberta Health Services. I also can't improve outcomes to the extent I could or should if I'm at the bedside and I have no support upwards when I pull on the rope. Top-down has to meet bottom-up if you're going to make change in outcomes and achieve the triple aim. And the other thing that I would say is that if you're going to change the practice patterns and behaviors of clinicians, it's got to be driven by clinicians. Sorry, it's not going to be done by anybody else. In the end, the quality of the care that they provide and the outcomes they receive are driven by their behaviors, their actions, their practices, and that's who has to be involved if you're going to make change. My final message would be that as you do this, we have been careful to build in a scientific director and a careful measurement and management process with evidence in each one of our SCNs. We now have 13 strategic clinical networks. We'll go to 14 within the next couple of months. They cover a wide spectrum of areas. We have a research program that helps aid and abet that, and we're driving this change through measurement and evidence. Put clinicians in the driver's seat. Give them a reason to make a change. Focus them, support them, and the changes will indeed happen. Thank you.
Thank you, Tom, and thank you, Andrew. So we'll open it up. We have time for questions, almost a half an hour for questions. And I should tell you, I learned a valuable lesson. Actually, Josh and I learned a valuable lesson about 2 weeks ago. We were at a dinner where the deputy was speaking, and at the end of his presentation, he said, "Are there any questions?" And no one asked any questions. So then he said, he pointed to myself and Josh, and he asked questions of us. So I know the names of some of you, and if I don't hear questions, I will be asking. And some of you think I don't know your name. Don't be surprised if I do. So I'm looking for questions. We do have a couple of questions from online, and I will get to those, but I'll open it up to the audience first. Are there any questions for our guest speakers? Yes, Lee. Yes, please go to the microphone. There's microphones on both sides of the center rows.
Sorry, hi. Can you
I think it's on.
Yes? Okay. Lee Donahue, I'm a GP from Ottawa. I'm wondering actually, perhaps hearing about what your experience as a family doctor and looking at the cost of the care that provides from the hospital and cost shifting that back into the community. And are you looking at any case costing in your HealthLink as to what is occurring in the hospital savings envelope, and is it getting distributed anywhere? What can you teach us about how you might go about formulating that? We have case costing mostly from a hospital perspective, and it's just a cool puzzle to try to figure it out. And I'm wondering if you guys have already done it, so we can just take it.
Yeah, we have not done that. We definitely have, every HealthLink has funding from both the LIN and the ministry as our sort of backbone infrastructure, but really the HealthLink is mostly run in terms of in-kind time from all the organizations. One would hope that as we go along, we're able to flatten the curve of sort of increase of healthcare costs to us in general. But part of that's going to involve us being more flexible in moving the money around. I think, there are various models to do that, and we have not done it. It's politically sensitive, I would say. I would hope as we are able to centralize things more with the regional health authority type model, which for us is the LINs, we will start to look at that piece, because I think probably the biggest opportunity for improvement in primary care, as you understand, is the access piece. I look around, we talk a lot about doing these things and don't do a lot of them. I think that's where we need to go. And access is going to take a change in the funding model, because to run a family practice 7 days a week changes the cost basis of that practice without increasing the revenue. And at the end of the day, there's cost and expense to all of this.
Could I just comment on that, please?
Yes, please.
You raise a really important issue because it's, in many respects, it's the gasoline that drives the engine. And let me say another way, benefits recovery and a payback model. That's what I will call it for now. You know, case costing in Canada is not exactly a sophisticated science at this point, my first comment, but we're doing better than before. To do it well, we're finally starting to get it done in Alberta because we can bring clinical and financial data together, completely together. I was surprised about how strong ownership was on one versus the other, and the ability to merge them has taken us like several years. We now can do a reasonable job at looking at and capturing the benefits from some of our work, and that's built into all of our work. We have to continue to prove our value because, you know, this is not beyond the inflection point and could get nuked, frankly, so we had to continuously show our value. Now, the problem is when you do this and all of these procedural things, the vast majority of them will result in substantial improvements in terms of productivity changes, but not too many actually result in real dollar savings. Because, you know, by and large, you've got to lay people off and close down beds and so on if you're going to really save money. So we do try to capture productivity costs, and we do capture real dollar savings, and we now have a shadow accounting mechanism for our projects at least, so I can tell you how many bed days we've saved. We can argue about how much that's worth, et cetera. I can show you the savings. Where we've failed now is being able to transfer those benefits back to the originators of the idea. That's the tough part, because now that we're starting to have results, everybody is claiming the victory. And how does the distribution work? What proportion it should work? And the fact is, when money was going into the system, it would have been easier. Now that it's coming out, I think what we're trying to do right now is retain our ability to operate, not expect new dollars from these productivity gains. But I think that the future will mean that we've got to track that, and we need to pay incentives back to the people that have the innovations and make the health status outcomes better.
No, and just on this, I really do, for the optimistic researcher writers here, it actually isn't really being well done in the world. And so possibly this idea of looking at those with high social determinant needs that are actually cost centers for all of us, and to look, how would we go across the clinical areas, look at the cost, case costing on a person, and how do we build it up to the population, and how do we take the population and drill it down? Like, I think we have to get there. I love your energy in Alberta, so, you know, we'll just take whatever you're doing, like, it's good. But I also think the research element is, no, but for this, like, if people have ideas, I think they have to share. And I think for the researchers, I'd really, or if I'm missing something in the literature, please just, I'll give you my email. I really do want to know what's out there.
Yeah, the ideas are transportable. The actions are context and regional specific, right? So you can plan at a provincial level or at a national level to the extent you want, but you always have to tailor make it to regional governance and working with the clinicians in their local area if you're going to make a change.
Thanks, Lee. I'll go to Reza and then Danielle, and then go to the online questions. Reza.
Since we're talking about regional, I'm wondering how the boundaries affect it, because certainly in a place like Toronto, people don't always get care where they live. I mean, I go near where I work. Then you have highly specialized organizations that will serve people from across the province. And what I'm concerned about when we talk about regions is if we're not looking at the particular sorts of services and populations we're trying to serve, and we set up barriers. So how do you find that regional models work for care that doesn't exactly fit within the regions that you're talking about? I mean, public health's another example. There will be no such thing as Toronto Public Health because Toronto's in multiple LHINs.
So I'll let Andrew and Tom think about an answer, and I'll try to say a couple of things related to it first while I give them some time to think about it. But, you know, it's nice to always say that the lines on the map don't mean anything except for administrators. Unfortunately, that's not the case, and it does get in the way of patient care and changes, approaches. It should not matter. That patients should be able to cross those boundaries, and it really should matter. Still to this day, we get specialists saying, I won't treat this patient, they're from another LHIN. And the two CEOs of the LHINs write letters and say, you know, you can't do that. That's inappropriate. We do have to recognize that Toronto is very different than the Southeast, and even Andrew's comment about in his particular area of the Southeast, there's one solo practitioner, family doctor, and in Toronto, Danielle, how many? And so there are differences, and it's always a balance of bringing in standard approaches and then reflecting those the uniquenesses of those regions. And so I'm not giving you an answer. I'm just building on your question and concern that you're raising. Andrew or Tom, did you want to respond or want to stay away from that?
Well, raising in 2008, we blew up the regions, so there's no regions that come to the table anymore, quite frankly. Yeah, well, okay. Just remember, everybody, I'm a newfie that lives in BC, so I'm agnostic. Regions are phenomenally good for program management. If I want to develop a clinical care pathway to change heart failure outcomes, I can do that well at a regional level, and I can program manage it. But, in the end, people go to a place and get their care, and they want it individual. And I think AHS has faltered in its early days because it didn't retain strong site-based management. When you're in a hospital, like when you're in a hospital, you want to know when something goes wrong, who the hell is in charge here, right? And there's better be an answer, and it better be in that building. And we are now trying to get the site-based management back. Bottom line, however, is that we can plan and put together clinical care pathways at a regional level or provincial level, but you got to adapt and tailor-make it to local area conditions. What we do in the North Zone is vastly different from what we do in Edmonton and Calgary, by way of example. And, now there is administrative structures in each of the 5 zones, but they're not regions like in the past. They don't have any autonomy. There's AHS Central, etc. So, it's 7 years in, almost 8. AHS is starting to work. Its administrative costs are down. Our outcomes are starting to get better. It's early times, but if you don't pay attention to what's going on locally and in site-based management with your care practices and so on, then you won't succeed.
Andrew, did you want to make a comment? Okay, Danielle?
So I have a question about disease-based versus population-based approaches to these questions. Andrew, you spoke about, and I think those of us who work in Ontario and have been involved in the HealthLinks experiment generally would concur with your conclusion that the disease-based approaches didn't seem to have worked nearly as effectively in the HealthLinks where they were tried as the sort of more population-based approaches. And I think that my sense of where we're headed in Ontario is we're trying to extrapolate that lesson of taking a more population-based approach across the entirety of the system. But Tom, if I understand the SCNs correctly, they're not, they're much more kind of disease-based, program-based, body part-based approaches to addressing variations in quality. And the examples that you talked about, whether it's stroke or whether it's antipsychotics or whatever, are a little bit more focused. And I guess I'm just wondering, do you think, and it's a question to all of you, it's a question to myself also, like, do we think that the future of quality improvement in these regional structures needs to have a different unit of analysis in the acute care sector than it has in the primary and community care sectors? Or are we going to try to go whole hog on this population-based approach, and is there something lost around clinician engagement when we move from body parts to populations?
Andrew, did you want to?
So just to take a bit further, we've actually started a disease-based program in our HealthLink just in the last couple of weeks around COPD, assuming that the prevention piece has failed. So we're not at this stage intersecting with public health, but it would make sense as we go forward to do that piece as well. I think from a clinician perspective, I think it's much easier for us to work on a disease-based system. I don't know what your feeling is around that. It's for people who have more research time, it's a different approach. And so to me, there's something in the middle. If you look at improving stroke care, it's a hospital-based service where care gets transitioned back to the community, ideally as quickly as possible. The intersection for us is a lot of those people are unable to leave their homes, so we have to get providers to the homes, and by that I mean physicians and nurse practitioners out of our offices. So that's the challenge on that disease-based thing. So I think from my perspective, from a community-based provider, I think we're going to have to change behaviors on a disease-based basis. I don't know any other way to say it, because if you look at the targets we set in QIPs, a lot of them are disease-based. Diabetes is the one that's been front and center for so many years. I personally don't see much traction on that, so I think we need to focus more on that piece.
So I agree with Andrew. You got to hook your population health interest to something else, and it may appear that by our names that we are body organ based. Not true. It's true that there is a focus in cardiovascular and stroke on the cardiovascular system, no question about that. But they've decided that they are going to adopt and initiate the Sea Change Initiative province-wide for vascular risk reduction. Okay, so there's 700 family physicians now. There are 78 pharmacies and the town of Whitecourt that are into the Sea Change Initiative, cardiovascular risk reduction. You will not get into one of those places without having your blood pressure checked or being asked about your lipids. We're seeing big changes in Whitecourt, where the mayor has now decided that he wants his whole town to become heart healthy. Bone and joint strategic clinical network. Yeah, we're interested in early fixation of fractured hips within 48 hours because that's what we ought to be doing. But at the same time, we're using that process to identify sentinel fractures in the emergency room to look for metabolic bone disease. So it's actually called fragility and stability. Fix the fractures quickly, but use a fracture event, particularly in young women in emerge, as a signal that they might have a metabolic bone disease and then do something about it. Maternal, newborn, child, and youth. Very population-oriented. So, yes, they look like acute care, and most of our signature projects we've been doing are related to clinical medicine and their outcomes. But every SCN has to have a remit in population health, and it must go to the end-of-life care.
So can I just ask one more question about that, though? So when the patient with the hip fracture goes back to community and goes to see their primary care doctor, and they've also got atrial fibrillation and osteoporosis and depression and, social determinants of health challenges, et cetera, the pushback that we hear from primary care, and I'm part of that community, we say, these categories don't make sense to us. And so how do you square that circle in terms of where our area of focus should be?
Well, let me agree with Greg. I love to do that. Rare as it might be, right, Greg? The most broken part of the Canadian healthcare system is primary health care. Primary health care, not just primary care. It's a shambles. I'm disappointed that we can't have visits with family doctors after hours. I'm disappointed we have not advanced the medical home and its philosophy. I'm disappointed we don't have attachment and accountability. So it's the weak part of our system in Alberta for sure. We have family physicians on all the SCNs, but do we really have the effective primary care voice there? Because of its chronic disease management, that's where 80% of the action is. It's the soft part of our process. And it's frankly being enveloped with the politics of the province, fee negotiations and what have you. It's got nothing to do with clinical practice. It's got everything to do with the context of medical politics in our province. And so we have the problem that primary care physicians are not as engaged as we'd like them to be. And if we're going to make real big differences, they have to be.
So there have been 4 online questions, and there's 2 themes. One is regarding electronic medical records, and I'll just state the questions, and then you can think of your responses. One question is, much of the ability to integrate primary care with the rest of the system depends on information exchange. Single EMR per sub-LIN, how do we do this? And the other question, similar, how will the LINs work towards integrating EMR better into the system? So Andrew first and then Tom.
That's not on. I'll just go. The consistent theme in our LIN, both on the HealthLink tables and the patient-first engagement we've done, has been leveraging IT. It's a consistent theme, and we're hoping in the Southeast LIN to use 2 platforms. One is the SHIP portal that includes medication lists, providers and family, advanced directives, the patient's voice in terms of their wishes for care, which sometimes is not what we expect it to be. And obviously the next piece is CNEO, which I think here in the Toronto area is CGTA, Connecting GTA, which is a clinical viewer that sits on top of the EMRs. At this stage, I just think it's it's too big a reach to integrate our EMRs. We spend so much money on interfaces and bridges and whatever you want to call them. I think to Tom's point on the chronic disease management, I think probably if I was to have one tool as an enabler, it would be the IT system. We should build an IT system that if I prescribe an antipsychotic to someone of any age, but particularly let's say over the age of 65, whatever age we're going to pick, it should stop me in my tracks, and it should actually ask me, why am I doing this? Make me override the indication and prescribe it. We have the technology, it exists. In our neighbors to the south, who will soon be outperforming us if you look at the metrics, have it in their large organizations. If you look at a lot of the work done about sort of standards of care in Ontario, we have them. We have these expert panels who agree on the right approach to gastroesophageal reflux disease. That should be built into the EMRs. And the only way we can do that is to get to one platform. So I know there's much talk about the money spent on it, but I think we're going to have to do it because, to Danielle's point, that patient coming back to the office after a hip fracture with identified metabolic bone disease, the most practical thing for the primary care provider to do is to focus on that disease process only. And so you miss out on the whole, you miss out on the fact that they maybe should be anticoagulated and you've missed that piece, you know what I mean? And they're sad and they're struggling at home. Well, you just ignore that piece because you're just worried about, is the wound healing on the hip and are they on the right medication? So I think there is definitely a possibility for us to leverage the IT to do that.
Let's just remind ourselves of the realities. In most of the parts of this country, very few exceptions, you can go to an emergency room today with a serious illness, and if we saw a family physician like Andrew yesterday, unless that was part of the history that the patient gave you, you'd have no idea that they saw a family doctor, that were prescribed medication, or what have you. That's the state of play in this country. That is shameful. So what's the policy objective that we need to achieve here, regardless of how we do it, whether it's with the InfoWay, provincial info structures, EMRs, with a, minimum data set, whatever. One person, one record. Easy, put it on your bumper. One person, one record. I don't really give up what architecture that you use. It matters. I don't care if it's multi-vendor, single vendor. Obviously, I care about the interoperability. One person, one record. Let's get on with it.
Thank you, Tom. The other theme comes from regarding how do we create regional integration with different models in place. What are your thoughts on regional integration versus integration through a rostered organization? And the other one, how does regional clinical governance for primary care look different for LHINs with high numbers of solo MDs and MDs on fee-for-service? So maybe again, I could start with Andrew and then Tom, you might give some thoughts to that also.
This is starting to feel like a Punch and Judy act. I'm not Punch. One of the key pieces from this morning's presentations was, I think it was bullet point 4 on the regional health integration plan, is going back to the clinical providers. And I mean it more than just the providers. I think there are solutions. We know that there's the spectrum of early adopters and never adopters. It may well be that the early adopters have self-selected themselves into family health teams in Ontario. But at the end of the day, I do think when you talk to someone about improving the healthcare profile of their patient, it's a very hard thing to walk away from. So I think that's where we have to go. And you talk about these different models. I have no idea what the number of solo physicians in Toronto is, but it's got to be in the high hundreds, if not low thousands. And so the thing for me is that we have vehicles to get information out to these people, and we have forums where we can sit people in the room and talk it through. And then generally what happens, I find we, being Canadians as we are, come to some sort of middle ground on these things. I mean, that's one of the sort of endearing properties of living in this country, I find. So the thing for me is that we're always looking at barriers to change, which makes us talk about something, write a paper, publish it, and it goes nowhere. We have to change this. I mean, I'm sorry to sound like Tom. I mean, it's no longer something we can talk about. You know, we all know the population demographics, and so I think the thing for me is that we have to accept the fact that there will be primary care providers who will not come to the table. We don't want to shame them or blame them, but the reality is, as the tide starts to turn, I think more and more people do this. I think we have to make it easier to provide care, which takes me back to the IT piece. You know, make it easier. I'm not saying take me out of medical school and give me Google, but what I'm saying is build in tools that give me the ability. And to talk to Tom's point about the emerge visit, the worst point is that patient might have had lab investigations done the day before as well that are invisible to the emerge provider. Increases cost, increases burden to the patient, and certainly does not help outcomes.
My bumper sticker version answer on that one would be advance the medical home in Canada. Its philosophy and the accountability associated with it, because coming with that will be things like the attachment process, the nature of the records, who's responsible, what have you. Advance the medical home. One person, one record.
So you'll all be able to pick up your bumper stickers on the way out. Please, I want to first of all thank those online for responding and providing questions, and also the audience for providing questions in here in this room. So I would like all of you to give a round of applause for Andrew and Tom.